Hello and good evening, everyone. As we all know that we conducted a quiz on Sunday on radiology, wherein I showed you 25 questions and 20 persons participated in the quiz and 50-60 others watched that quiz online on Google, on this YouTube and also on the Google Meet with me. So today I'll be discussing answers to that quiz questions 25 and we'll be discussing the questions in detail. So here we start. The first question of the quiz was identify the normal sinus variant. So here arrow was marked at the sinus variant. So four options were given: nematized basal lamina, concave bullosa, laminar bulla, and bulla ethmodalis. So nematile basal lamina and concave bullosa are the when the nematization is present in the middle terminate here, it is called the concave bullosa. Bulla ethmodalis is the most prominent anterior ethmoidal hair cell. This was the lamellar vertical segment of the middle turbinate. It was nematized. It is called as lamellar bulla. So the correct answer to this question was C, lamellar bulla. So this was the second question wherein I asked you the question regarding 52-year-old male with left vocal cord palsy. So this statement left vocal cord palsy should draw your attention towards the AP window. So you need to see any lesion in the AP window which actually was present here. There was an homogeneously enhancing lesion present within the, this is the aorta, this is the pulmonary artery. So this is the superior vena cava, this is the pulmonary veins, and this is the aorta, descending thoracic aorta. So there was, and this is the trachea. Near to trachea, you see a homogeneously enhancing lesion. So for this a homogeneously intensely enhancing lesion, all of these are the differential diagnosis for this lesion. But if you see unicentric Castleman disease, it shows enhancing nodes. Mediastinal paraganglioma, intensely enhancing lesion. Metastatic carcinoma from renal carcinoma, thyroid carcinoma, or from carcinoid met. It can show homogeneous, this bright enhancement on post-contrast images. But carcinoid in itself is an enhancing tumor, but the option was tracheal carcinoid and it is obviously outside the trachea. So the correct answer to this question was tracheal carcinoid. This was another question wherein I asked you about a 35-year-old male with nasal obstruction. So this is the T2 weighted image, T2 fat on. This is the T1 postgrad image. So here you see a polypoidal mass which is arising from the lateral nasal wall from the turbinate and it is going and growing into the right maxillary sinus via the antrum. So the answer to this question was inverted papilloma. So A. Fungiform papilloma, they typically arise from the nasal septum and they don't arise from the lateral nasal wall. This is the nasal septum and the mass is pushing the nasal septum towards the other side. So this is not arising from the nasal septum. Also antroconal polyp, they grow from the maxillary sinus via the antrum into the nasal cavity. But the characteristic appearance of this tumor, which is convoluted cerebriform pattern, which you can see here, the tumor looks like a polypoidal, like a cerebral folia. You see, so it is very typical of inverted papilloma. This is because the basement membrane over which there is this mucosal, the polypoidal mucosa is present that grows on histopathology. You see the basement membrane is going down into the stroma. That gives the tumor its name of inverted papilloma. So the answer to this question was A, inverted papilloma. Nasopharyngeal angiofibroma definitely doesn't involve this area of the anatomy. But the tumor is present within the nasal cavity, not in the nasopharynx. That grows from the nasopharynx into the nasal cavity and also back into the oropharynx down anywhere. But this predominant epicenter of the tumor in this case is in the nasal cavity only. So the other next question was identify the procedure and its contraindication. So here you see vertebral body which is fracture reduced in height. There is marrow edema. So and this is the fluoroscopic spot image which shows a spinal needle going via the pedicle to the vertebral body. Here balloon is starting balloon. They are inflating the balloon inside the vertebral body. So this is the balloon, inflated balloon, and after inflating the balloon, they have injected the cement PMMA into the vertebral body. So basically, this procedure is kyphoplasty. Vertebroplasty and kyphoplasty, they're different because in kyphoplasty they cause this balloon inflation within the vertebral body and then they inject the cement into that cavity. The benefit of kyphoplasty or vertebroplasty is that it helps to increase the height of the vertebral body. Although both the procedures are same, just involves the kyphoplasty involves the inflation of balloon into the vertebral body. So like all the contraindication was asked, infection remains the contraindication for this procedure. So the correct answer to this was C, kyphoplasty. The procedure is kyphoplasty and contraindication of the procedure is infection. Medicine, in fact, is a indication to perform this procedure, kyphoplasty. And apart from infection, coagulopathy is also a contraindication for this procedure, as is the contrast reaction, sorry, any allergic reaction to cement, bone cement if present. So next question was a common abdominal vascular variant. Identify the marked vessel. If you see, this is the aorta. So here, this is the IVC. This is the renal vein which is joining the IVC. So this is the duplication of IVC. So you see two vessels around the aorta. It is not the portal vein as most of you might think, because the vessel is quite posterior where the aorta is visible, and portal vein is actually, there are multiple draining veins which drain into the vessel. This is the main channel. No vein is draining into it apart from this renal vein. Second point is, it is very posterior as compared to the location of portal vein, which is into the renal hilum. Renal hilum is located more anteriorly. This location of this vein is posteriorly. So this is uh, duplication of IVC actually. So the marked vessel is IVC, not aorta. Aorta is this vein, and portosystemic shunt is not. This is not a portal, because this is not a portal vein. So the marked vessel was IVC. So we move on to next question. The next question was, pair procedures indicated for which WHO stage of hydrotest? As you all know, hydrotests, they are classified according to Garbi classification and WHO classification. So these are the six WHO stages of hydrated cyst as per the WHO classification: C1, 2, 3A, 3B, 4, and 5. So the question was, pair procedure is indicated for which of the WHO stage of? First of all, I'll tell you, pair is the percutaneous aspiration, re-injection, and percutaneous aspiration, injection, and re-aspiration of. So herein we percutaneously puncture the cyst, aspirate the contents, then re-inspect the various solutions. They are injected as colicidal agents, in which normal saline, beta D, most of the products, they are used as colicidal agents. And then after some time, that instilled material is re-aspirated back. That causes the killing of that hydrated cyst, and later on it calcifies. So this procedure is indicated in C1 stage, where there is simple cyst like this case, and in C3 where you see this water lily sign. It is not done in C2, C3 way, where there are multiseptated multiple cyst daughters, because you need to inject, then you need to inject separately into each of these daughter cyst. You need to perform pair for this cyst. So there are numerous cysts. So this is pair is not done in case. Surgery is preferred in such cases, both in C2 and C3B. It is in the background of solid matrix. In the background, it is no solid matrix is present. C4 and 5, they are calcified, they are dead, they don't need any treatment, they just need observation. So the answer to this question was C3A. Answer also would have been C1, but that was not given in the option. So the correct answer was C3, option C. We move on to next question. So identify the facial fracture pattern. So as you know, in the midface, in the craniofacial skeleton, actually the midface skeleton, leaf fold fractures are there, very commonly seen. Very important question also. All the leaf 1, 2, and 3, they characteristically involve the pterygoid plates. Along with the pterygoid plates, if there is separation of maxilla from the rest of the facial skeleton, it is leaf 1 fracture. It is actually a horizontal fracture which moves along the. There is separation of maxilla from rest of the facial bones, and with involvement of pterygoid plates. In leaf 2, the pterygoid plates are involved. The fracture line is more vertical and pyramidal shape, which involves the nasal bone and the zygomatic bone. In Leaford 3, the lateral orbital wall and the zygomatic arch is involved. So all the Leaford fractures, the basic content or basic thing to classify them as Leaford fractures is the fracture of pterygoid plate, as it is seen in this axial CT image and also in the coronal CT image. You see the fracture of pterygoid plates. But apart from fracture of pterygoid plate, if only the maxilla fracture is present, is 1. If it involves the nasal bone also and the orbital floor, it is 2. If it involves the lateral orbital wall and the zygomatic arch, it is 3. And the Wassermann classification, it is classification of the mandibular condyle fracture. Here it was in the VRT image, you see this is not the mandibular condyle, this is actually the pterygoid plate, which is evident in the coronal and axial image also. So Wassermann classification is for the fracture of mandibular condyle. So the correct answer to this question was Leaford 1. So we move on to next question. Identify the IR instrument. As you see, this is Perclose. Company name is Proglide. So Perclose is the vascular closure device. Also the Angioseal is a vascular closure device. They are both used to seal the puncture site of vessel. In most of the procedure, we take a puncture of 5 French or 6 French in the arterial, and in venous we can take a larger puncture. But most of the time we just remove the sheath after the procedure and do the compression. Compression is a very effective way of sealing the that puncture site. But in cases where the puncture site we need to insert a instrument, catheter, or some sheath which is of larger size, we need to perform, like in case of TVAR procedure, sometimes we need to create a hole which is as big as 20 French in size. So in that case, we need to close the arterial puncture site either surgically or with the use of these devices, which are vascular closure device. This is just like a stitch mark. It goes into the vessel just like any other instrument via the help of the guide wire, and then it forms a suture around the puncture site to close that opening. And this angioseal, there is a collagen vascular plug which seals the vessel from inside in case of angioseal. So though these both are vascular closure device, they are not biopsy guns or biopsy site markers. So identify the abnormality in the given spot, barium swallow image of infant. So here you see the fundus of stomach and the gastroesophageal junction, they are displaced up into the thoracic cavity. So this is sliding type of hernia. Morgagni and Bosdalek, they are present in the anterior and posterior, respectively, in the anterior, right anterior and left posterior location in the crus of diaphragm. And rolling hernia, it involves the G junction is present below the crus of diaphragm. Only the other portion of stomach, usually the stomach fundus that goes alongside the esophagus into the thoracic cavity. But here you see the gastroesophageal junction that is up into the thoracic cavity. So this is sliding type of hiatus hernia, and it is definitely not Morgagni or Boschlag hernia because they are more anterior and they don't involve that hiatus. They involve the crus of diaphragm anteriorly and posteriorly. So identify the procedure being performed. You see there is a guide wire which is going. This is the stomach shadow. This white one, this whole is the stomach. So this is the inflated stomach. So this is the guide wire. This is the puncture site. The guide wire is going via the puncture site into the stomach, taking a loop into the stomach and then going towards the pylorus. So and also you see these clips. This is the puncture site clips, which are the uh, gastrointestinal coupe sutures, which actually are used to hold the stomach wall close to the abdominal wall cavity, uh, so that we can guide and we can push all the guide wire, the catheter, and then the actual gastrostomy tube into the stomach. It pulls these sutures, they pull the stomach they abut the stomach closely to the abdominal wall, so that it is easy for us to puncture and do other and put other things like the wire and the catheter from that opening into the stomach to perform the percutaneous gastrostomy. So in case of NG and NG tube, I would have shown you the images where the wire was entering from up above from esophagus into the stomach. So here the wire was going directly from the percutaneous side. So this was the clinch to diagnose this case was a case of percutaneous gastrostomy. So definitely it is not PTBD, it is into the stomach and it is well below the site of liver. It was not a PTBD. So moving on to next question. Next question was a 55-year-old female with anemia and renal failure. So this clinical history is very important when you are answering a question. Just read there are most important points while answering a question because we have clearly mentioned patient had anemia, renal failure, diagnosis. In the skull, you see the inner table, outer table, and medullary cavity. They are well preserved, normal. But you see these multiple small lucent defects which involving the calvaria homogeneously. Also, the pituitary was normal. The rest of the bones of the calvaria and the vertebra, involving vertebra, they look pretty normal. So the diagnosis for this case was not Paget fibrodysplasia or macroadenoma because the sella was normal. Paget's disease, it involves the inner and outer table, but the table were normal. And fibrodysplasia, the medullary expansion, ground glass haziness, nothing was visible here. Only the athletic multiple. So simple answer was multiple myeloma to this question. So moving on to next question, 32-year-old male with bleeding PR and diarrhea. So the history is very important. Bleeding PR, you should just go and have a look at the rectal region and Diarrhea is due to this because this was a carcinoid intensely enhancing tumor with multiple enhancing deposits into the liver. So answers were multifocal SCC can show these multiple arterial enhancing lesions, multiple SCC, but there won't be any lesion within the rectum in case of multiple because a rectal deposit from a multifocal SCC is very rare. The more presumptive diagnosis or more appropriate diagnosis in this case was rectal carcinoma with hepatic mets. Although multifocal SCC can also look like this in case of single arterial phase images, but you won't see a rectal mass there. Also, prostatic carcinoma is not this enhancing on contrast images, and also it doesn't show liver metastases which are hyper enhancing. Usually, the prostatic carcinoma it metastasizes to bones, as we all know, and sclerotic mets to the bone. CLD with internal hemorrhoid. This is not a picture of CLD. The liver looks normal. The also this CLD doesn't show these multiple enhancing lesions. So the answer was rectal carcinoid with hepatic mets. This was a double point question for in the quiz. So moving on to next question. A 45-year-old smoker with right flank pain diagnosis. So right side you see hydronephrosis, the kidney is thinned out, cortical thinning, there is hydronephrosis. As you go down, you trace the ureter, it is dilated, dilated, dilated here also, dilated here also, here also. But you see a polypoidal lesion here. You see a polypoidal enhancing lesion which is filling the ureter, lower ureter. The diagnosis was ureteric TCC transition cell carcinoma with proximal hydronephrosis. Bladder was normal, there was no stone, there was an enhancing mass within this distal ureter. So next question was 26-year-old male with altermentation and fever diagnosis. So if you see the spectroscopic image at 0.9 to 1, there was a peak, lipid lactate peak. So this was the clinching diagnosis for this. And there was this thin ring enhancing lesion into the right cerebellar hemisphere posteriorly, which shows T2 hypointense wall central. Although this central area in tuberculoma, usually the central area is T2 hypointense, but this was maybe the tubercular abscess which was formed into the. So this was a case of tuberculosis. Also, you see here there is pachymeningitis, leptomeningitis. Sorry, this is leptomeningitis, and there is one lesion also here in the right cerebral hemisphere, one in the cerebellar hemisphere with lipid lactate peak. So the diagnosis to this was sinus tuberculosis. It was not anesthesia because lipid lactate peak. There lymphoma usually this is not the location. They are not multifocal. This is not the location. This is not the enhancement pattern which you see in lymphoma. This is actually thick kind of enhancement in lymphoma. They are usually periventricular in location. Glioma doesn't show lipid lactate peak. Although high-grade glioma with necrosis sometimes can show, but the enhancement is thin and smooth enhancement. They usually show nodular enhancement. So the next question was identify the syndromic pattern. If you see there is small cyst within the pancreas body and tail region, and there is this heterogeneously enhancing mass in the kidney. So pancreatic tumor, renal tumor, the diagnosis was VHL. NF1 and NF2 doesn't show involvement. Renal cell carcinomas. Birt-Haf-Dubé do shows, but pancreatic involvement is not seen. But renal tumor in Birt-Haf-Dubé, they are renal oncocytomas. They are not renal cell carcinomas. Also, what are the other features in VHL like you see they can show you any association of tumor in questions, like they can show you cerebellar hemangioblastoma, they can give you history of past history of operation of cerebellar tumor. Then you see endolymphatic sac tumors are there, and then retinal hemangioblastomas they are there, cardiac rhabdomyomas. So there are multitude of findings in various manifestations in VHL. You go and read them because syndromes like especially the phacomatosis, they are a very favorite question of all the examiners. So you should be knowing all the associations and tumors, especially the tumor. They'll show you 2 3 tumor in images and ask you the question regarding the tumor. So be careful about syndromes. And next question, very important question. This was my favorite question of the quiz. 50-year-old female with pain right upper quadrant raised ALP. Alkaline phosphatase was raised. So pain and CA19-9. So you see CA19-9 is the tumor marker for pancreatic carcinoma and also a tumor marker for cholangiocarcinoma. So you see that this is the MRCP actually. This is the MRCP images where you see multiple linear strands of T2 hypointensity filling the dilated ducts of the liver. This is the kidney. This is the kidney. So these are the ducts which are filled with. If you see the MR image here also, the ducts are dilated and filled with T2 hypointense some structure. On contrast, CT you see again the same finding. So there are intraluminal polypoidal lesions within the bile duct. So this is one of the very uh, very important diagnosis of intraductal papillary neoplasia bile duct. It's just like the biliary counterpart of IPMN. Previously, it was called as IPMN of bile duct. Multiple of names like biliary papillomas, IPMN of bile duct. But now they have classified these tumors into mucinous neoplasms of biliary system, which includes mucinous cystic neoplasm of liver and intraductal papillary neoplasm of bile duct. The main histopathological difference between MCN of liver and IPNB is the ovarian-like stroma, which is present within the mucinous cystic neoplasm. They are usually seen in females around 40-50 years of age. They are usually benign. They don't harbor any malignancy in most of the cases. In some cases, they do harbor malignancy, and then previously they were called as biliary cystadenomas, biliary cystadenocarcinomas, but nowadays they are called as mucinous neoplasm, mucinous cystic neoplasm of liver. They are mostly benign tumors, but as compared to the intraductal papillomas like these papilloma, intraductal papilloma, papillomatous neoplasia of bile duct, they most of the cases, most of the time they show malignant potential. Like in most of the 40-50% cases, they harbor some malignancy within the bile duct as compared to their other mucinous counterpart of which is the intrahepatic. They're usually extrahepatic involve the extrahepatic bile, but in our case, it was involving the intrahepatic bile ducts also. So read a article about mucinous neoplasms of biliary system. Like in pancreatic counterpart, the IPMN is having less malignant potential as compared to the mucinous cystic neoplasm of pancreas. But here in bile ducts, the mucinous cystic neoplasm is less having less potential malignancy within it as compared to the IPNB. So IPNB is more malignant potential as compared to mucinous cystic neoplasm of liver, and IPMN is less malignant potential as compared to mucinous cystic neoplasm of pancreas. So these are the key highlighting differences between these mucinous cystic neoplasm. We'll read an article about it. So the next question was, which T2 hypointense synovial lesion doesn't show hypointensity on GR images? So very commonly you see a case where there is within the joint there is hypointense lesion, synovial proliferation, hypointensity. So these are all are the differences of this T2 or hypointensity, which includes PVNS, pigmented villonodular synovitis, as this case is, amyloid arthropathy, hemophilic arthropathy, synovial osteochondromatosis. So they all are the differential, because in hemophilic arthropathy also there is recurrent bleed, hemosiderin deposition, synovial proliferation. Osteochondromatosis, the pathology remains the same. The synovial proliferate, there occur osteochondromatous metaplasia of the synovium, which is also shows blooming on GR images. But the amyloid deposition is also actually T2 hypointense, but characteristically it doesn't show hypointensity or blooming on GR images, which differentiates amyloid arthropathy from rest of these T2 hypointense lesions of synovium. So remember, if you see a T2 hypointense lesion which is not hypointense and blooming GR images, you should think about amyloid and look for the cause of amyloid. Moving on to next question, young female recurrent episodes of left-sided DVT. This is the recent case I saw. Patient lady presented with DVT left-sided. They asked for the knee compression syndrome. We traced the vein. It was there here. Now ultrasound we could also trace it. So this is the right common iliac artery. This is the left common iliac artery. This is the left common iliac vein. This is the IVC. If you see, this is the right iliac vein. This will join. Contrast was injected. The lady in the contrast in this case, arterial phase contrast. The contrast was injected via the iliac vein. So you see in no. So you see there is a filling defect within the iliac vein, and these are the two iliac artery, and this right iliac artery is compressing on the left iliac vein. So this syndrome of vascular compression syndrome is the May-Thurner syndrome. Median arcuate ligament causes compression of celiac artery. Nutcracker causes compression of left renal vein, IVC thrombosis, because this is not the IVC, this is left iliac vein. So the answer to this question was May-Thurner syndrome. Moving on to next question, animated 3D image showing shoulder joint. So this is the this is the Hill-Sachs defect within the posterior superior quadrant of the humeral head, and this is the Bencard's defect, Bencard lesion. So here you see this defect is larger than the this Hill-Sachs defect, visually larger. So this is an off-track lesion. An off-track lesion, there is risk of engagement is high and risk of recurrent dislocation is high, because So the answer, identify the false statement, is the given lesion is on track. It is not on track. On track is when the length of this this Hill Sachs defect is less than the actually glenoid tract. Glenoid tract is actually 83% of the glenoid width. Glenoid width in this case is taken in CT on coronal images. So you take the best fit circle method is the technique. You go and read about it, on track, off track lesions in case of recurrent shoulder dislocation, and what is the significance of it, because you can guide the clinician regarding the treatment. Because if the lesion is off track, it is large, you need to replace this defect with some bone. That is the procedure, the surgical procedure is done in which they take the coracoid process and fill in the coracoid process here, so that there is the risk of this engagement and recurrent dislocation is reduced, is not there. So go and read an article about how to measure this Hill Sachs interval, what is glenoid tract, how to measure glenoid tract, how to measure this interval. This Hill Sachs interval is measured in on axial images, and this glenoid tract, which is this, is measured on coronal CT coronal images, which is actually the 83% of the glenoid width. So how to do it? Go read an article about it. So next question was 6-year-old with groin pain for 1 week, no trauma, febrile, with normal count, ESR and CRP diagnosis. So here you see there is on this, these are the X-ray pelvic image, this is the T2 and T1 weighted images. If you see the epiphysis is normal on the X-ray, also on the MR also, superthesis is ruled out. Slipped capital femoral epiphysis. This is actually a type 1, that Salter-Harris classification type 1 injury, where there is a fracture line through the growth plate. There is a fracture here in the growth plate, and this femoral head, it slips superiorly and laterally from the femoral head. It goes out into the from the inner lower quadrant. This head goes. Epiphysis remains there. It's actually a misnomer. Epiphysis doesn't slips. Epiphysis remains in the quadrant, but the femoral head, femur, neck, and head, it goes, it displaces superiorly and laterally. But the fracture line, so there is no fracture line. The growth plate width is normal. So Perthes head is normal. So you are left with transient synovitis and septic arthritis. But you see, he's febrile with normal count and ESR and CRP. So he is not septic arthritis because the counts are normal. So the diagnosis in this case, you see the T2 hyperintensity, seminal inflammation, and fluid in the right hip joint. So this was transient synovitis. The next question was, identify the procedure being performed with the given images. So this is Chiba biopsy needle. If you see, it is written here Chiba biopsy needle. So this is done to take the FNAC sample, FNAC, because this is the length of the needle is large, like 18 centimeters is the length of this needle. This 22 gauge 18 centimeter. Comes in various lengths. The normal LP needle is like 8 to 10 centimeter. But this is long length needle, and black, it is black in color, it is 22 gauge. Black is 22 gauge. So if you see in ultrasound guided console, they are going, this is the vertebral body. So they are going towards the vertebral body in just in the pre-vertebral space, in the retroperitoneum. So these are the bowel loops, these are the stomach. So they are going, needle is into the pre-vertebral space in the retroperitoneum. So this is the location of tumor is just above the celiac origin. This is the celiac artery origin. So if you see, this is the aorta, this is the celiac artery. So they are going just adjacent to the celiac origin on ultrasound guidance. So this is the procedure of celiac plexus block. Vertebral biopsy, we take a sample of vertebra, we go posteriorly via the pedicle, not from the anterior. Gastric and pancreatic FLC, definitely they are not doing it because they are into the prevertebral space. So this question was actually, what is the artifact? MR artifact, identify the MR, post-contrast MR angio artifact. So in post-contrast MR angio artifact, there is one venous contamination when you take the images in a delayed phase, when the contrast has already reached into the venous system, as you can see in the image. The contrast, these are the arteries, and these are the venous channels. The contrast, we have taken the delayed images. The contrast has reached into venous system also. This is a venous contamination artifact. Maki artifact is when it is called ring artifact or ringing artifact, something like that. It occurs when you acquire the images before the contrast has reached into the arterial system. in the post-contrast angio images, if there is mismatch in the timing of this image acquisition, and you time the image acquisition such that the image is acquired before the reaching of contrast into the arteries, so the marquee artifact is seen. In that artifact you see a vessel in which there is loss of signal in the center of the vessel, and periphery of the wall of the vessel that it enhances. There is an enhancement in the wall of the vessel. This is called marquee. In plane saturation is seen in 2D, 3D TOF, especially in cases of circle of Willis. If the artery, if the usually in TOF, what happens, the inflow, there is an inflow phenomena. The blood comes, it gives the signal. But if the all the blood which is in the horizontal plane or in the same plane, it gets saturated due to the saturation pulses, which saturates normal tissue also. So if the vessel is not perpendicular, it is parallel to the imaging plane, parallel to the this magnetic field or the saturation field. So it will not take up this inflow phenomena, and there will be an flow wide, that is in plane saturation artifact. And Venetian blind artifact is a specific type of artifact in which it is specifically seen in this MOTSA, multiple overlapping thin slab acquisition MR angiography, in which we take multiple slabs like this slab to 5 slabs acquisition. Then we just suture them together to make one final image. But there is some signal alteration different, just like a uh, Venetian blind at first. So you remember sometime they asked all of these artifacts, any of one of these artifact image can be shown and asked which type of artifact, or Venetian blind artifact specifically they asked where it is seen. It is seen in case of Motsa. Remember, it is only seen in case of multiple overlapping thin slab acquisition Motsa images. So 50-year-old male habitual IV drug abuser diagnosis. So if you see here, this is the round polybundle enhancing mass, which is it is actually intraaxial mass. It is abutting the falx as you see. But had it been for meningioma, you would have seen a dural tail because it's post-contrast CT image. There is no dural tail, and glioblastoma usually this large. It shows enhanced necrosis, then hemorrhage, all those features, because it is glioblastoma multiforme. So there are no multi, this is homogeneously enhancing with some small area of cavitation or necrosis. Homogeneously enhancing tumor, it is cortical based, hyperdense on non-contrast CT. So a patient is 50-year-old male, habitual IV drug abuser. This was a marker towards the HIV. Hematoma, definitely it is enhancing tumor, it is not an hematoma, not glioblastoma, not benzoid. The answer to this question was primary CNS lymphoma. Which of the following is not a contraindication for MRI? So definitely cochlear implant, cardiac pacemaker, and intraocular ferrous foreign bodies are an indication. IUCD was not a contraindication for MRI. So 32-year-old male with left leg claudication diagnosis. So if you see, this is the vein, this is the artery. So the wall of the artery is not clearly visible, although you see some cyst closely associated with the wall or adventitia of the artery. So this was the case of cystic adventitial disease of popliteal artery. Although cystic adventitial disease can affect any of the peripheral arteries, but it is most commonly seen in the knee region. So here you see this cyst. This is the artery, this is the vein. They are closely associated to the wall of the artery. Also in the ultrasound image, you see there is narrowing of this artery here. This artery's caliber is good here, good out, distal to the good proximal to it. But at the site of the cyst adventitially, there is some narrowing. It can cause claudication. This patient had claudication. This was the last question of the quiz. So this was the last question of the quiz. I hope you liked all the questions and you are clear. You have cleared your doubts. If you had any while attempting the quiz, I have tried to explain them all. But if you want to know anything more about any of the question, or you have any doubt, you can just write down to me in the comment section. I'll be happy to answer them all. Thank you so much. Good night.